Many a times in the ICU or even in OPD, a patient BP might be on the higher side. The resident might include it under a hypertension, which is very common, primary hypertension or essential hypertension. But there are situations where some other etiology, specific etiology or a treatable etiology can be there, which is causing the high blood pressure, or which might be a presenting feature of some other disease element which is inside, which is there is some cause. That hypertension comes under secondary hypertension. The topic of discussion today is what are all the features to suggest or points favoring towards a secondary cause of hypertension. Before starting the possible etiology, what is primary hypertension or essential hypertension? No particular etiology is found. A patient BP is on the higher side, probably a family history might be present. More of lifestyle related factors, which comes under primary or essential hypertension. Secondary, as the name suggests, high BP is manifestation of some other particular etiology. So this is the difference. Coming to the point suggesting secondary hypertension. First, BP might be extremely high at the presentation itself. Past history might not be there. A patient presents for the first time with headache or some other symptom. BP might be more than 180 systolic. Diastolic more than 100, 110. A systolic is more important at this point. First time presentation with a very high BP, always look for some secondary cause. Second one, age of hypertension onset. Age even less than 20, you have to compulsorily look for secondary causes. Less than 40 years, which comes under young hypertension category. More than 60 years, first time onset with high BP. So less than 20, always look for secondary cause. Less than 40, which comes under hypertension category, young hypertension category. In this, one point to add is, in the text you might get varied values for the age. Sometimes 30, sometimes 40, some textbooks 35. On an average or standard basis, you can take as less than 40. Less than 40, more than 60, first time presenting, not in the background history. First time presentation with extreme high BP. The second point suggests of secondary hypertension. In a short duration of time, this is the third point. In the short duration of time, patient present with extreme end organ damage. What is that end organ damage? Retinopathy out of proportion to the history. First time itself patient presents with papilledema. First time itself a severe hemorrhage or hypertensive retinopathic changes are there. Acute LVF, CVA, AKI, the manifestation of which might be TMA, thrombotic microangiopathy. Not into the details of the TMA and all, just any end organ or target organ damage at the presentation itself. Without a chronic background history, at the presentation itself, presenting with end organ damage is very, very rare in primary hypertension. You have to look for secondary causes. Fourth, non-responsive to drugs or patient needs more than 2 or 3 drugs for BP control. For example, a patient was recently found to have high blood pressure. Antihypertensive medications were started, but the BP is not coming under control despite giving 3 drugs. I have to tell the technical terminology. Yes, it's resistant hypertension despite taking adequate dose, because most of the primary hypertension get controlled with even 1 drug if the lifestyle changes or obesity, those things are under control. Whereas in secondary, the control of the BP might be very difficult. So this is the fourth point, where the more number of drugs might be required to control the BP. Fifth one, the family history or some lifestyle attributing factor might not be there. Obesity might not be there, family history might not be there. All of a sudden, these kind of high BP presentation. This one contributing factor, not the only factor. Family history, depends on the reliability from where you are asking. Sometimes they might not have checked in the family members, those and all is there, but it is a contributing factor. Last one, examination finding. What you will get in the examination. For example, asymmetrical pulse in the upper limb or in the lower limb. Palpation of the pulse is very important. And also in the examination, some features suggestive of secondary diseases like in the form of pedal edema, which might suggest glenoparenchymal involvement, abdominal bruit, even any point suggestive, sweating, orthostatic hypotension. These kind of things might favor towards pheo, which is very rare, pheochromocytoma I mean. So in the examination, what more thing you will get commonly? Probably a joint pain suggestive of autoimmune etiology. Another example is renal artery stenosis, which might lead to the finding of bruit in the abdomen, or asymmetrical pulse, which might be suggestive of some kind of vasculitis, or a feature suggestive of Cushing syndrome, high cortisol or any iatrogenic pushing because of the drugs. Moon phases, striae, these kind of secondary finding might be there. So all these points favors towards secondary hypertension rather than a primary hypertension. So these are all the things you have to look for before labeling the patient as primary hypertension. And in the clinics, most of the primary hypertension present as mild to moderate one, usually well controlled with the drugs. Most of the time, family history might be there, history of smoking, alcohol, some kind of obesity might be there, stress factor, a high amount of caffeine intake, this kind of cool drink intake, these poor lifestyle related changes might be there in the primary. Those might act as a confounding factor. Despite that, you have to look for this. Even if it is there, look for this. So this is the topic for discussion completed. In summary, if I have to tell, take age into consideration, extremes of BP, uncontrolled BP, end organ damage, a patient without any past history, and always look for examination finding. Yes, of course, you will be able to catch most of the secondary hypertension. If this step is complete, because we discussed the history and examination part, further investigations are there. With that, you will try to find out or max out your diagnostic approach. Bye bye, we will see in the next video.